I just want to welcome you all to today's Town Hall series. It's been about just over a month. We are very happy to have everyone back and joining us today. So I'm Dr. Enid Stiles. I'm your current CVMA president, only for another couple of weeks. So after that, you get to have our next incoming, who is Dr. Quantes. Very excited for him to take over this really privileged and wonderful role that we have, that we are so honored to be able to provide to our members. So thank you very much, all of you, for your support this year. And it is exciting for me to introduce Dr. Weese once again as our primary person on the Town Hall series to give his insight and knowledge on where we are with this pandemic presently. So I'd just like to remind everybody that this is going to be a recorded webinar, so you are able to access it online at our website. Usually within a few days or a week, it will be available. So you can, if you missed anything or had to leave early, you can always have a listen. Or if you wanted to tell your friends to have a look, it is open access. Also, just to remind you to keep yourself on mute, especially if you have to come and go from the meeting today, just replace yourself on mute. And it's just easier on the system if your video is closed as well. And if you have any questions during Dr. Weese's presentation, you're welcome to use the chat box. We'll be watching that. Dr. Weese is really pretty amazing at checking that while he's speaking. I don't know how he does it. So he'll probably be answering along the way, but certainly do use that. And if there's some questions that we can't get to, we'll try and jot them down and make sure that we can get to them to you personally at another time. So I think on that, we've got just about an hour to have this webinar today. We'll stop a couple minutes early so everybody can get back to their jobs and their work. And hopefully, if you're in my situation, we're in the green in Quebec now, well, I'm able to open up a little bit more in my practice, and it's making my team very, very happy. So I'm going to pass it along now back to Dr. Weese, if I can get out, which I never am able. There we go. Thank you. Super. Thank you, Scott.
All right, great. I think we're all set up. I'm just gonna pull the chat up. So as Enid said, thanks for coming back. It's good to see people still having some interest in this. I've got a couple different topics I want to go through today, but we really want to focus on the things you want to talk about. So as she said, put it in the chat. We'll keep an eye on that as it goes. The four main things I was planning on covering, a little update on variants of concern, basically an update on Delta and why that's relevant. A quick animal update, just because you might be hearing some things in the news. Not a lot has really changed, but just I'll touch on a couple things. Probably we'll focus on reopening considerations, and a lot of this circles back to various concepts that have been discussed before, but we'll try to bring that together a little bit more. And misinformation. This is one of our big barriers with vaccination right now, and it's one of these things that's slowing down or maybe preventing us from getting to that level that we really need to have for that, magical herd immunity that we're all aiming for. So starting out with the variants of concern, and you probably know, I think since the last one, or maybe right before the last webinar, the nomenclature was changed to get rid of all the numbers and letters. And now we're on alpha, beta, gamma, delta, and down. So the big concern right now is delta. Alpha was that UK variant, the B117, the one that dominated in Canada once it emerged here. And it's largely being pushed out in most areas by delta. And this is the variant that originated in India. And is quite highly transmissible. And this variant it's the real deal. It's a concern. So if we look at the original Wuhan strain, still gets called, the original SARS-CoV-2, the R0. So this is, we've talked about this before, the number of people your average infected person will infect without taking any measures is about 2.4-ish. So your average infected person in the normal state will infect 2.4 people who will then infect 2.4, and off you go. Alpha, the UK variant, was much more transmissible at 4 to 5 and also caused more hospitalization. Delta is even more than that. Delta, I think 6 to 7 is kind of where we see a lot of stuff, but that 5 to 8 range. So your average person without controls will infect 5 to 8 people. So you get a really rapid exponential growth with that. Delta also has a few other issues that are causing problems. It certainly does cause severe disease in unvaccinated individuals, may result in more hospitalization, but just the greater degree of transmissibility has big implications. And we've talked about different numbers that we need for herd immunity. So percentage of the population that's immune through natural immunity, if that's protective enough, and through vaccination. And originally the discussions were around the 70% range. And they maybe haven't shifted that much, but when you consider who can be vaccinated, and that's 12 and up, with Delta and its transmissibility, we probably need 90+% of people that are eligible for vaccination being vaccinated. So we need 90% or more of the 12 and up group to be vaccinated to get that level of control that we need to have herd immunity, keep it at bay. And that's not to eliminate it, that's just to keep it at bay. Now, Delta's causing problems in various places. We've seen a shift here, and basically we've gone from one strain to another strain and now to Delta, corresponding to some waves. But just to show what Delta can do, this is Vietnam. So Vietnam's a country that's controlled this virus very well. They were very strict at the start. They were very successful at the start. They had little waves or wavelets that were pretty small and controlled. But then they had another one that came in recently, and this one wasn't as controlled or controllable. And that's because it's Delta. And this shows what happens when you get a more transmissible strain. Even if it's maybe not tremendously more transmissible, you get a more transmissible strain in the population, you can get into that exponential phase growth. We're not expecting that here. We're hoping we aren't going to have a fourth wave. We have good vaccine coverage. So we can still have transmission and still have a lot of issues with disease and serious disease in our unvaccinated population, but probably not going to see a big wave, but we certainly still can see some issues. Just one more last thing about Delta. This just shows, this is Ontario. So this shows from December, the case counts and the strains that are there. So if you look at the start, the orange is basically the non-B117 or the non-alpha variant. So we had the normal strain at the start, and then we knew this UK variant was coming in. We knew it was going to gradually build up, and it hit pretty much bang on with the models. It became dominant, and then that wave got controlled. And what we're seeing here is this UK strain Alpha is getting to be quite small, and it's being replaced by not the original strain, but non-Delta. It's non-Alpha. It's being replaced by Delta. So the short version of this is we've seen normal strain, then to the UK variant. Now we're seeing a shift to that Delta variant. So this is becoming a predominant strain across Canada, and because of its increased transmissibility, that's our concern. So like I said, we need a high level of vaccine coverage. The vaccine efficacy is still somewhat debatable. There's some Israeli data. Israel's a country that's got very high vaccine coverage and had very good control. They started to loosen up. Delta got in and it's caused some problems. The data they have is suggested 64% efficacy versus 90-some% for mRNA vaccines for Delta. UK data haven't been, they've shown some decrease, but not quite as profound. So I think we don't really know how much Delta affects vaccine efficacy. The assumption is it doesn't protect quite as well, but it still is quite good, especially for severe disease. So if we look at data just from the other day in Ontario, our Delta cases, and this isn't hospitalized individuals, this is just people that got infected. Most of them were unvaccinated. 83% of people that are infected with Delta were unvaccinated. Only 1% were fully vaccinated. So vaccine breaks do happen. They're just not that common, especially in the doubly vaccinated population. And then again, this is just infection. It's not serious disease, because serious disease seems to be very rare in the doubly vaccinated population. It can happen. It's not a zero risk thing, but we can still have transmission of this in the unvaccinated population and quite good protection in the vaccinated population from severe disease, which helps maintain hospital capacity beyond just obviously the severe disease components. So Delta is a concern though, and if we don't get that vaccination coverage up, we are going to see ongoing issues, ongoing strain in the healthcare system, ongoing illness and death, predominantly in the unvaccinated population. And I'm just checking, there's a Delta question there. Is Delta Plus more of a concern? So Delta Plus is, WHO came up with this nice nomenclature system, and then India just said, we're going to call the next one Delta Plus. It's basically a variant of Delta. So whether it's actually a new variant of concern, we don't know. At this point, I think we just don't know if it's a new strain. There's also a strain called Lambda that's a variant of interest, not quite a variant of concern yet. And we're going to see more of these, because the thing is, variants emerge because of transmission, and transmission is not well controlled internationally. Transmission is not well controlled in some places where you have really good vaccine coverage overall. Southern US is a ripe for the picking place for new variants because they've got a lot of unvaccinated population, limited public health measures, and a lot of transmission. So we are going to see more variants of concern to come up. We'll see if Delta Plus is actually a big deal. We'll see if Lambda becomes a big deal. Delta is probably not the last one we're going to talk about. Hopefully, we'll still have the same theme as well. Transmissibility might be different, but severe disease rates will be low in the vaccinated population. We are worried about a vaccine breakthrough. Vaccines don't cause vaccine breakthroughs. That's one of the kind of the misinformation things that are out there. Transmission causes vaccine escape mutants. And the worst case scenario really is you have a pretty good vaccine coverage in the population, and you have a lot of transmission. So you have a lot of random mutations happening. And if one of those makes that strain able to affect vaccinated people, then we've selected for it. So, and again, Southern US is actually maybe one of the worst places for it because you've got good double protection in a small, 40% of the population maybe, and you've got a lot of transmission outside of that. So the vaccinated people are protected right now, but if those unvaccinated people make up a bad strain, then that can make it into the vaccinated population. So we don't tend to see a lot of risk for true vaccine escape mutants with infectious diseases, beyond influenza with the antigenic shift, but it's certainly something that's still of concern. There's a question there. Actually, I say this is direct, but there are a couple of questions coming in about adverse effects, and I'll cover that at the end, just because I'm going to get into some misinformation stuff. So that hopefully sets the scene a little bit with our variants. A couple slides just on the animal stuff, because you might have heard some things. Dorothy Beansley and I have an abstract in a European conference, the big infectious disease meeting there, and they've released some information on it in advance of the conference. So it's been in the press a little bit. Basically, it's the same stuff I've been talking about before. If we look at our dog cat population, they're susceptible. They don't usually get very sick, but they are susceptible. So this is our study where we got a couple different components. We're doing PCR testing of pets from households where there's active COVID in people. So people are actively infected, and we're looking for the presence of the virus in the animal. And then we're looking at seroprevalence, which tells us retrospectively, was the animal infected at some point in the past? And we're doing that in households that had COVID. We're also doing that in a shelter population and in a low-cost spay-neuter clinic population that does stray, feral, as well as low-cost spay-neuter. And just quickly the results. This is a bit of an ugly slide because PCR takes a little bit of time to explain what the results mean. Basically, what this slide says, if we go into a household and people have COVID, not often do we find an animal that's actively infected. So we can see they were negative in 93 or 72% of cases. We had some that were inconclusive, borderline positives. A lot of these were probably real positives, if not all. They're just a low level of virus shedding, and some that were clearly positive. So your average animal in a household where someone has COVID is not actively infected with the virus because it's a point in time, right? They shed for a short period of time. We have to get in there at that right period and sample them and get a positive. So that kind of equates to the situation where we've got a positive household and we have to see that animal in the clinic. Odds are pretty low the animal is infected at that single point in time, or at least infected enough that there's an appreciable amount of virus there. But we do see a lot of transmission in the households if we look serologically, which is a composite sample of all the time the animal was in there with the infected person. And in cats, it's about 2/3 of the cats from positive households had antibodies. Dogs, it's a bit less, but still pretty impressive at 43%. And this isn't too far off other data from some other places. It's a big study out of Texas. They're a little bit lower, but we're fairly similar overall. In that, a reasonable percentage of cats in particular will get infected. Just a couple of things from the study, a little bit interesting. So new clinical signs. So having antibodies was associated with the owner reporting the cat was sick at the time the owner was sick. Now, this is owner, it's subjective, but they didn't know whether the cat was positive or negative at the time. So, it's reasonable. So cats that were seropositive were 6.5 times as likely to have had the owner say there were something different about them at the time the owner was sick. Sleeping in the bed. This is actually second time this has come up. There's a Brazilian study that reported the same thing, but if the cat slept in the bed of the owner who was positive, they're almost 9 times as likely to be seropositive. And that makes sense. Close contact, prolonged contact, small airspace. You come back to ventilation a few times. Being licked or kissed by the owner makes sense, but 5 times as likely to be positive. Dogs, I'm still not really convinced about the clinical relevance of this. We did have an association of people reporting new clinical signs in the dogs when they were sick. And it was statistically significant, but they were really mild. The people that were reporting things were typically, yeah, the dog was a little bit quiet or something like that. You know, they weren't over severe respiratory disease. They were very subtle findings. So my guess is that, yeah, it does cause disease in some dogs, but it's pretty mild. Cats are where we'll see more typical upper respiratory tract and occasionally more severe disease. If we look at the non-household populations, it just reinforces what we know about people, right? If you sample a bunch of people off the street, we're going to find seropositive people, some that knew they were infected, some that didn't know they were infected. And since we see transmission to cats fairly frequently in households, we get that reflected. So from before, 67% of cats from positive households. If we look at the spay-neuter clinic, we're around 12%. This is still going on right now. Some of these were from households where there was known contact with a positive person. A lot of these were cats where there wasn't much information. So they were purchased off Kijiji or some other way. So they don't really know what the owner's status was. So these presumably had lived with a positive person. We just don't have that in their history. Humane Society, we had a smaller group there. We had some positives. Most of the positives were surrenders with a limited background info. And these are in the Toronto area. So with, you know, a higher risk area for infection, it would make sense that a lot of these were, you know, true positives, unknown exposure, but still a big difference from our household group. And then there's mink. I won't get into mink much. So we've had 3 farms in BC that have had infections. I don't think that's anything particular about BC. Part of it might be bad luck, and part of it might be them doing a better job looking and reporting. We don't have a lot of mink farms in Canada, but there is variable response to how they're being tested across the country. So this is still an issue internationally. We still are worried about mink because of their susceptibility, the widespread transmission, potential for creation of mutants and spread back into people. I guess maybe the most noteworthy thing about mink right now is potential for vaccination. So the zoetis vaccine, you might have heard recently, is being now used on some zoos for some of their higher risk species, the wild felids and the primates to be the big thing, as well as vaccination of mink to try to prevent its getting onto a farm and spreading on a farm when an infected person brings it in. And I'm just going to pause here for a second before we get into reopening, see if there's anything I've missed there. I think stuff we can hit at the end because it kind of relates to more of the human vaccination stuff. So I'm going to talk about reopening considerations now. And this is where if you have questions, put them in. If things to discuss, we don't really have, there is no standard way to do it. There are a lot of things you have to consider when you're thinking about how to reopen, what to do. Hopefully what we're not going to go is from 0 to 100 in a day. Going right back to normal isn't necessarily what we want to do. And in some ways, you know, the new normal should be different than the old normal just to protect us from this and various other things that we're kind of cluing into. But overall, you know, I've used this slide a lot of times. You might be sick of it, but the 3 things that we worry about or we pay attention to with respiratory virus transmission is the 3 C's. And these are things we want to avoid: closed spaces with poor ventilation, crowded places, lots of people, and close contact. And this does describe a lot of situations in a clinic. And there are things that we can adapt. So, you know, staying out of closed spaces with poor ventilation or improving ventilation, limiting crowding in a specific area in the clinic overall, and limiting close contact. So you can have a lot of people around, but if they're spread out and they're well ventilated, the risk of that is minimized. And this is where we need to layer on different protections. And we need to think about how these get used as we kind of roll into normalcy. And this is the Swiss cheese approach, where we're using things like distancing, ventilation, masks, hand hygiene, you know, cleaning and disinfection. All vaccination is on this one. This is an older one. All the things that we try to do to minimize the risk. As we start taking away some of those slices, or we start weakening some of those slices, then we need to figure out, you know, can we compensate with some of the others? So we're putting more people in the clinic. We're decreasing distancing. Okay, well, does that mean masks are more important? Does it mean ventilation is particularly important? So as we modify one, we need to think about how we can optimize the other, and then ultimately what our goal is. And this is going to vary by clinic. So some of you may have seen this. This is our latest version of guidance that we put out with the OVMA. This is from a couple of weeks ago now, I think it was, and we've got a section in here on reopening considerations. So there's some that's fairly Ontario specific, but I think the concepts really do apply elsewhere. But when we're thinking about reopening, I think things you need to think about are vaccine coverage, and that includes your staff, and that includes people in the area. If you have really good vaccine coverage in the population, and you have good vaccine coverage in your staff, then the clinic has less of a concern of infecting its own personnel because you're well vaccinated, and being a focus of infection for the community, or a mixing vessel for the community where one unvaccinated client comes in and gets exposed from another unvaccinated client. Not for anything we do, but from in our airspace. The VOC dynamics in the area. I think basically now you assume Delta is taking over. If a new variant comes along, that's something we would need to think about as we kind of scale up or down practices. A big one, I think, is the ability to optimize the control practices that we do and optimize ventilation. And ventilation is a huge thing that we've never paid enough attention to. And it's something that we really can do a lot of improvements with. I'll come back to that later on. I've talked about it a lot before. Risk aversion is part of it too, like how it's cost benefit, right? The more you open up, the more risk we create. So we need to think about what the benefit is and how that cost benefit relationship fits with you and your clinic personnel. How motivated are everyone to really get going back to normal? And part of that can be risk status in the clinic. If you've got a clinic that's full of doubly vaccinated young people, risk is going to be really low to them. If you have unvaccinated people that can't be vaccinated for medical reasons, people that despite vaccination are still at higher risk for severe disease, immunocompromised individuals where vaccination is not as good, then that might alter your approach. Like two clinics down the road from each other might have completely different approaches because of the dynamics of their population and their risk aversion and the implications of this virus getting in the clinic. And I think part of it is how easily can we implement kind of hybrid measures to baby step it in? How easily can we do things to still minimize the number of people that are in the clinic, but get more toward a normal approach? So I'm gonna pop into the questions here for a second, and then I may hit some of these as we go through. So how do you approach the fact we can't really ask staff or clients are vaccinated? Actually, I'm gonna come back to that a little bit more. This is a tough one. How to deal with vaccination is really not been tested well enough. And human healthcare is doing it. There's a lot more pressure now to require vaccination in healthcare personnel. And a lot more serious pressure than was even a couple of months ago. And that becomes an issue. So I'll come back to the staff vaccination in a second. HEPA filtering in the exam rooms. Is it worth it? And I would say absolutely yes. So I'll hit on ventilation a little bit more too, but the more we can improve airflow, especially in places where we have small air spaces like an exam room, we tend to put people together, we tend to be talking for sometimes a reasonable period of time. That's the high risk situation in our clinic. So I think those in-room HEPA filter units, they're fairly easy to get now, are certainly a way to go. Once staff are double vaccinated, we'll be able to be maskless in the workspace. And again, this comes back to your risk aversion. So and how you do it in the back end of the clinic versus the front end of the clinic can vary too. So if everyone's vaccinated and you've got other good measures in place, then you might say we're going to decrease masking in our workspace. You still might want to do things if you're in close contact with each other. You're bending down face to face, putting a catheter in. But if you've got a low risk population that's doubly vaccinated and you've got the legal ability to do it once mask orders get withdrawn, that's certainly the first population you start thinking about doing it. So staff in a back room that's well ventilated, well distanced. And you probably do that before you start removing the masks around clients. But I'll jump back to the questions in a bit. So I'm going to keep focusing on this that I've talked about a few times. So, vaccination. Like we aren't going to vaccinate our way out of this, but vaccination will get us there a lot quicker. Ventilation, like I said a few times, is really huge. Reducing the numbers of people in the clinic. It's just more fuel for the fire, the more people that are in there and more risk that comes in. So reducing the number of people that come in overall, number of people there at any one time, and the number of people in any one area. And this gets to the 3 C's. So fewer people there overall is good. Fewer people there at the same time. 20 people in a clinic at the same time is different than 20 people spread out over the day. Or 20 people in a lobby is a lot different than 20 people dispersed around a clinic. So we need to think about how we can spread people out and how we can minimize the number of people that are in there and how they're acting in there. Distancing, how much we can distance. And then, as has come up here, continued use of PPE. And I think we have to be careful we don't open up too quickly. PPE masks are easy to wear, and I know there's a lot of personal issue and political issues around masks. Masks are easy to wear and they're effective. And the data are that they're effective. So as you're starting to change things, I'll equate this to a patient that's on antibiotics, because that's my thing, right? So we got a patient that's on broad spectrum antibiotics, and he's on a couple different antibiotics. Do I want to stop them all, or do I want to de-escalate? I want to de-escalate, so if things go wrong, I know what's happening. So if I stop 2 or 3 drugs and it spikes of fever, which one of them was useful? Do I need to go back on all 3 to get things under control? Versus if I step down, okay, I stopped this drug, that's fine. Stop the next drug, got a fever. Okay, we're going back on that drug. Same thing with practices. If we're more careful with how we step things down, we probably have a less chance of having to step everything back up at the same time, if that makes sense. So things to consider. Hybrid appointments. Again, the more we can do to mix things so that we don't have a lot of people in the clinic at the same time. Getting people in the clinic is different than allowing everyone in the clinic. Some people don't want to come into a clinic. Some people don't really need to come into a clinic. Some do. Or it'd be better for their care, for us, for them, for to be in the clinic. So maximizing the benefits of having people in the clinic, while also maximizing things that we can do to keep people out. Drop-offs, could be outdoor, could be more telemedicine, things like that will hopefully hybridize our approach. Outdoor activities, Winnipeg in February, we're not going to do this, but outdoor activities can be useful. Again, we're just trying to decrease the number of people in the clinic. I'm not doing surgery in the backyard, but there might be some, really basic rechecks. Let's look at the sutures or remove the sutures. It's a nice day. We can do this in the back if you've got an area like that. Could be owner communications, could be calls, could be paperwork, sit on the picnic table and type up medical records if you have a laptop. So things that we, do again, just to decrease that number stress that happens in clinics, especially clinics that are small and busy, which describes a lot of our clinics. Clinic occupancy. So this is where there's a lot of provincial variation, and this changes as you step through different areas and colors and whatever your system is. So, the default is check with your province. Guidance usually isn't very straightforward, and it doesn't necessarily apply because we're not, we're lumped into retail typically, but we're not the same thing as a store where most of the footprint of the store is client space. We have a small client footprint in the clinic. So you could say that, okay, you're X thousand square feet. So, you can fit this many people under X thousand square feet. Yeah, but you wouldn't normally have them in there. So we really need to be thinking about how we consider capacity and how we consider that if we say it's 25% or 50%. And we've got some wording in the OBMA document with some comments from the Solicitor General's office. So, which we're not very specific, but basically the expectation is you need to be able to distance. So the number of people occupancy thing doesn't really work for our type of situation. So what I say for your exam room, or sorry, your lobby, for example, is, step back, take a look. How many people could be in there and maintain 2-meter distancing without having to do a dance every time someone moves? Right? What's a reasonable number of people that could be in there and you would expect them to be able to do their thing without getting closer than 6 feet apart? And that's your capacity, right? So, and then as we loosen up, you can probably squeeze them in a bit more. But as we're trying to still be restrictive, you still want to be able to maintain that distancing. And I won't go over all this. This is just basically an explanation of it, but there are some nuances that you need to be aware of depending on your province. And again, this is Ontario, and your capacity depends on what you do. So if a clinic is doing veterinary care, but is also selling things in the clinic or through curbside, that includes food, there's a different capacity than if you're just doing veterinary care. So at the time this is written, the phase this is written, you get a 15% capacity. If you're selling stuff, you get a 50%, 50 versus 15 if you're doing veterinary care. So you do have to be aware of some of the things that might be particular to your province. Okay, pop to the chat before we get into vaccination. I think there might be some comments there. BC and Alberta don't have any requirement to wear masks indoors for social distancing unless businesses set their own policy. And that's the problem, is businesses are kind of set to be the bad guys. And, I had discussions with various types of business owners from those areas, and I've seen information from more. A lot of businesses are just kind of doing what clients want them to do. But there's a reasonable number that are saying, we ask you to wear a mask to protect you and protect us, right? It's just no shirt, no shoes, no service, no mask. You can do that. You have to decide how aggressive you're going to be about it. And again, that comes back to, what battles do you want to fight? What's the layout in your clinic? If you had a really cramped clinic with high-risk people, low vaccine coverage, poor ventilation, I'd be a lot more worried about having people maskless inside than if we do everything else right. So that comes down to, again, that Swiss cheese approach. If you're in an area where you know people are going to come in wanting to not mask, can we do everything else optimally to reduce the risk of that? Are the personnel in my clinic low risk because of their vaccine status or their health? Can we do other things to protect them? Or do we have to say, no, we're requesting you wear a mask, or if you don't want to wear a mask, we'll do curbside, something along that line. So the questions I've got, I think, next come into vaccination. So I'm going to cover this is a controversial area. It's an area that, you know, no one really wants to be the subject case on. So can you make staff become vaccinated? Can you ask for vaccine status? Can you ask clients about vaccine status and change what you do? And I think more and more, not really consensus, but more and more opinion now is saying, yes, you can, because of the issue. And it depends on the type of business, depends on whether it's unionized or not, is a big one. And I think we're seeing it in various areas. Universities are a good example with residences. Initially, you know, there was no desire to try to make a mandatory vaccination policy for students in residences, even though everyone kind of wanted it. No one really wanted to go there because of legal issues. No one wanted to get sued. And now a bunch of universities have done it. So we're requiring vaccination for students that want to come into residence because it's an elective thing. You can choose whether or not to go there, just like you can choose whether or not to do a lot of things. So the choice aspect kind of comes into play. So from the OVMA document, we kind of took, this is with some legal input. So there are considerations there depending on the workplace, the contract you've got, reasons for and against vaccination. The focus really is on encouraging vaccination as opposed to mandating vaccination, providing incentives for people to get vaccinated, you know, time off to get that done, everything we can do to try to get vaccine coverage optimal without, you know, making them do it. So this is what we have in the OVMA document, that, you know, adopt a policy that would recommend but not require them. You know, personally, I'd rather see if we could require them. And I think we are getting to the point where it's going to be more supported that you could require it if you wanted to, as long as you had an exemption for true medical contraindications. You know, I don't wanna is not a medical indication, contraindication. I can't be vaccinated because my physician says I can't have this type of vaccine. That's a medical contraindication, and that type of person should be protected. The I just don't want to because I don't want to is not a medical indication. But there's been more stuff. This is just a screenshot from a Toronto Star article from a couple of days, or last week maybe. And you know, the person in here, and this is just one person's opinion, but it's an employment law specialist, an HR specialist, said, if your workplace is in Canada and it's not unionized, employers can terminate employees for any reason as long as it's not discriminatory. If an employee chooses not to get vaccinated because of personal choice, then the employer could choose to terminate them. I'm not saying fire your employees, but I'm saying there is consideration there. And again, this comes down to your clinic too. If you've got people that are at high risk for getting sick or can't be vaccinated and getting everyone else vaccinated, or you've got an area where what you do in the clinic may be impacted by vaccine coverage, you know, I'd rather get it done on a discussion level, but this is what's coming up more and more. You know, I think really the focus is we try to encourage vaccination. One of the things that comes up has been similar to what's been tried to do in flu and human hospitals. Okay, if you're not vaccinated, you have to do this, that, and the other things. If you're not vaccinated, you have to wear a mask, even when everyone else doesn't have to wear a mask. That one actually gets kind of dodgy too, because you're pointing out to everyone who's vaccinated and who's not. So there's actually, I think, becoming more hesitation to require unvaccinated people to do something different that might stigmatize them than to say you have to be vaccinated. But this will be tested most in human healthcare. Long-term care is where it's really getting pressed now. There's an outbreak in Ontario. Well, there are various outbreaks in Ontario. There's one where there's a death the other day, and there's only 52% vaccine coverage amongst staff, which is completely, I think, unacceptable from a control standpoint. So we're going to learn more about this. And I think that's about all we can really say right now. If vaccines aren't required, can you ask them to wear a mask? Maybe that was right before I started to say that. So you can, again, we just don't know what it means. I think it's a reasonable thing to do. You know, could someone sue you for it? Sure, someone could sue you for anything. I think it comes down to the person too. If you can say, okay, you really don't want to get vaccinated, well, okay, how are we going to reduce the risk to you, you know, and from you in the clinic? And having you wear a mask longer may be the reason. And, for a lot of people, that would be a big incentive to get vaccinated. Because some people, it's just inertia is the issue. They're anti-vaxxers and they're vaccine hesitant. And then there are the people that just don't bother because they're young and healthy and they don't think it's a big deal and they haven't bothered. And that's how we kind of drive some of that group. A couple other questions. I haven't caught up. I think we've got most of them. Yeah, staff members that won't get vaccinated are a concern. Really, that's the educational approach. And then it comes down to how big of a battle do you want to fight over it. I see there's a question there about AZ, the first dose followed by Moderna, the second dose. That was me as well. This question about will that be accepted for travel? It sounds like it will be now. The US is now, I think, said they'll accept WHO approved vaccines, not just US approved vaccines, because US never approved AZ. So if you got AZ and followed up with an mRNA vaccine, you're considered doubly covered now. And that's changed as a couple of weeks ago. The question about fertility concerns, I'll come back to that in a minute when we get into misinformation. So keep tossing questions up. I'll see if I can keep hitting them. I'm not going to get into this one too much, but there's been a big debate. There's been evolving thought about how this virus spreads, right? We know it's direct contact, droplets, things like that. More and more aerosols. The question is about aerosol to airborne. So, with aerosols, we're talking, you got droplets that settle out pretty quickly. They're big particles when you breathe. They don't go very far. You've got aerosols that are smaller particles that hang out in the air for a little bit. So I'm talking here, I'm making big droplets that settle at my keyboard. I'm making smaller droplets that will waft around me and I create this cloud around me that, if I'm infected, would be an infectious cloud. And then there's airborne where that cloud disperses and stays there for a while. There's infectious virus in the air for a prolonged period of time. We've gotten, I think, pretty convincing evidence that this is an aerosol disease. This infectious cloud is a big issue, and that's why ventilation is really important. The airborne components, it's like measles, is a highly transmissible virus. The airborne component, we don't really know, but there are enough little reports to show that airborne transmission can happen. And this gets relevant in clinic situations, really reinforces why we need ventilation. And this is an outbreak in a hematologic ward. And I won't get into all the details, but the airborne component here was someone that was infected, they believe, from a bathroom that was used by an infected person, I think it was 40 minutes before. So the person was in there, they created this infectious cloud, and it stayed there for that long period of time. And there have been some other reports of virus seeming to move through ductwork in apartment buildings, for example. It does not seem to be a common cause. It probably relates to a really highly infectious individual super shedder and the right circumstances of airflow. But you never know who the super shedder is until they've infected everyone. So this brings in some more concerns in clinics, especially when it comes to our air spaces, right? So the exam room, if we don't have good ventilation in there, we've had someone in there for 15 minutes, do they pose a risk for the next couple of appointments if they've created an infectious cloud that's in there? So again, reducing numbers, maintaining masking, improving ventilation, all those things will help reduce the risk of that happening. So ventilation, I'll go through this fairly quickly. We've gone over it before, but basically we're looking at kind of three main things we want to do. We want to get stuff out. So fresh air out, bad air, or fresh air in, bad air out. We want to disperse clouds, so there's lower dose. And we want to kill or filter out virus. And those are the three approaches that we can do. And we can use them in parallel. So airflow, we can disperse things around. So if I'm sitting here and I'm making up this infectious cloud around me, but there's really good ventilation, I'm moving that out. And you can say that's good or bad because maybe I'm moving into the next room, but I'm more likely going to reduce the risk by making this a lower density environment. So we're trying to disperse it. We're trying to remove it. So airflow that goes from inside to outside, or opening doors and opening windows. And then there's filtering, like we mentioned before, in-room Hepa filters, in-room UVC. Hepa is just a better proven technology. So that, again, we're in that small airspace where ventilation is not great. We're killing virus that's in there. So we're dropping that infectious dose down. So this is really important, something we haven't paid as much attention to as we should. And it's going to protect us against any respiratory virus long term. So things we need to think about in the clinic, opening windows when you can, not very easy in most clinics. It may not be possible with a lot of HVAC systems and clinic designs. Cranking up the HVAC as much as possible, bringing in as much fresh air as possible. Again, that's a challenge with your system when it's really cold in particular, or when it's really hot and the air conditioning's on. So that leaves us with in-room systems. And these little portable Hepa filters, they're becoming fairly ubiquitous in some areas like dentistry. They're in most dental rooms, which are kind of similar to our exam rooms. So they're relatively cost effective. They will reduce the amount of virus that's in there if they're a proper HEPA filter. And they're a practical solution to areas where we can't do other things, such as improve distancing and improve airflow very well. You can do above room systems where you get these things that are mounted at the top of the ceiling for UVC or for HEPA. They work quite well too. They're good for in rooms. They're more expensive. And then you can get UV or HEPA in the ductwork. And this is where it's less relevant. Like if it's truly an airborne disease, you got a super shedder in there and that's being sucked up in the ductwork. Yeah, HEPA or UVC in the ductwork is going to help, but that's a really uncommon situation probably. And these systems are expensive. They need to be maintained really well. They're not something that's going to be a mainstream treatment, and really they're not recommended in pretty much any situation. So focusing on the more adaptable, cheaper in-room filter system is better than putting a lot of money into your ductwork, because it's that in-room area where you can have the most impact and where you have the most risk. Monitoring, this is something I've talked about before. CO2 monitors, I've got a couple. I know the ventilation in my house is crap. It's really well sealed and our CO2 level is quite high. Our clinic actually is really good. We've got really good airflow through most parts of the clinic. So you can get CO2 monitors. You can get them for $150 for a fairly good one, or $700 or $800 for an analytical one. But the cheaper ones work pretty well. And outdoor, we're looking at about 400 parts per million. A well-ventilated room, under 800. We'd rather have it under 600. You start getting above 1,000, you start getting worried, just in terms of how much ventilation you have. So you can stick them in exam rooms. You can have a bunch of them, or you can have one you move around to get an idea. And then, okay, you stick them in your lobby and you realize, okay, your CO2 creeps up a certain time of day or certain types of activities. Well, what can we do? Can we open a door? Can we open a window? Can we change the ventilation? Can we add a fan and move things around differently? It's a fairly easy thing to do. And I think it'd be good for all clinics to have an idea how good their ventilation is. So take homes, improve your ventilation. I never thought I'd talk as much about ventilation as I do, but it's really important. Crank up the HVAC, open windows when you can, use fans, bring in HEPA filters for high risk areas, exam rooms, small treatment rooms, maybe surgery suites. If your ventilation is not very good and you've got multiple people in surgery for long periods of time in particular, think about CO2 monitoring. And ultimately, again, the fewer people that are in there, the lower risk. So the more that we can do those 3 C's, reduce the number of people at the same time in the same area in particular, the less stress we have on ventilation. Okay, I'm just going to pop into questions and we'll get into misinformation. What do we have here? If someone was vaccinated with one-shot J&J, should they get a booster? That's a big question. The J&J vaccine was designed as a single dose. It's not been that impressive a vaccine. Like it's a very good vaccine in terms of what we were hoping to get. It's not as good as the mRNA vaccines. I think my guess is people that got J&J will in the not too distant future get an mRNA vaccine. And I think if people that had 2 mRNA vaccine doses are going to get a booster at some point in the not too distant future as well. But the J&J is it's a reasonable vaccine. I wouldn't have huge confidence in it as a long-term one-shot. But I think the jury's still out, and it's not used widely enough in most areas to have a lot of data on it. But I think that's why we're assuming you're going to need a second dose. Any studies with AZ followed by Moderna, same as AZ and Pfizer? I have a mental block on that. I don't think I've seen one out yet, just because there's been less Moderna used. But basically, Moderna and Pfizer are to some degree same shit, different bottle, right? They're same technology. Moderna is a much higher dose that's in there. They work the same way. We're going on the assumption they're interchangeable, and that's why there's been the guidance that if you got one mRNA vaccine, you can get a booster with a different one. So you can go from Pfizer to Moderna. So we basically consider them the same type of vaccine. I think we were too specific in our communications about vaccines, right? We should have just said vaccine, or should have said mRNA vaccine versus adenovirus vaccine. Right. So, and then mRNA, who cares what it's Moderna or it's Pfizer, it's the same thing, because we're trying to convince people it's the same thing now. So I think I haven't seen data specifically on that, but I think there's basically no concern about interchanging Moderna and Pfizer after AZ. Okay, so keep tossing questions in if you have them. I'm going to get into misinformation because it actually comes up with some questions that have come through in the chat. So one of the questions was, fear of vaccination adverse effects on fertility, which has been a really unfortunate misinformation campaign because it's having a big impact. And we're seeing this internationally where statements that are being made that are based on bad data or downright lies are being having a big impact on vaccine. And again, if we need 90% vaccine coverage for Delta of our vaccine eligible population, if you lose a few percent of people to misinformation, that could be a huge difference. So what do I mean by misinformation? Well, this is the stuff that's getting out there on the internet, social media and the like, that's talking about vaccine adverse effects and about being an experimental vaccine, about, we're now participating in a phase 3 trial without knowing about it, with all these adverse effects that happen, things like this. And why is it happening? Well, scientific literacy in the general public is poor, right? I think we know that. That's part of it. And when you got someone that can kind of throw some science terminology around, your average person, not surprisingly, can't tease out what's real and what's crap. Misinformation is causing substantial harm. The number of people I talk to that have family members that have not been vaccinated because of misinformation is really astounding. The number of physicians I've talked to have had patients cancel appointments. Like this is not a little niche thing. This is having a significant impact on vaccination. Some of the misinformation campaigns can be subtle and believable. You get someone that, you have some reasonable stuff in there or stuff that makes sense. You bring in a lot of science, bring in some fancy terms, you make some nice infographics. Your average person can't sort that out. Obviously, we've had politicization of his disease, and that's been a big problem, right? The vaccine uptake very much varies, especially in the US and political spectrum, rural versus urban, various other things. And we do see that in Canada too, just not to the same degree. And we've got some vaccine nationalism, which doesn't really deal with the misinformation, but maybe the willingness to accept misinformation. I see some ventilation questions coming in. I'll get back to them after, so I'll make sure I hit those at the end. So you just have to be aware of the misinformation campaigns, because I've actually talked to a reasonable number of vets who have had people that don't want to get vaccinated in their clinic because of misinformation. Typically young female technicians, often because of fertility concerns. So I think we need to be aware of this for getting vaccine coverage in our clinic. Plus just we get asked everything, right? Because we're in the medical field, and I think we need to be aware of these. So the misinformation campaigns, like this isn't just the odd crackpot saying stuff. Like these are well organized, they're ongoing, they're well funded. Some of them are very profitable through some of the ways they collect money, and they're often very believable based on misrepresentation and pseudoscience. And like I said, they're causing big vaccine hesitancy. So I'm just going to go over a couple of these. So masks are harmful. There was a paper that came out the other day. I'll talk in a few slides that kind of fed that fire. And again, it was complete crap. The vaccine's called magnetism. That should be a pretty easy one for people to say, yeah, I don't think so. But it's amazing the number of people talk about that. Vaccines cause infertility. I'm going to hit on that in a minute because that's one of our big things right now. Vaccine cause a large number of complications. Like people like absolutes. Can a vaccine cause an adverse effect? Yeah, right. Can driving down the road cause an adverse effect? Yeah. Can taking aspirin? Yes, but people don't want to accept that with a vaccine. They want a 100% guarantee, and we can't offer that. And that leads to people opening the doors about massive number of complications. And you also see things about vaccine adverse effect reporting. Now, you may be familiar with the VAERS system in the US. It's a vaccine adverse event reporting system. So that's where reports get submitted, but they're not scrutinized, right? So what you'll see is there are thousands of people that died after this vaccine. This is a very common thing. Yeah, but thousands of people would have died anyway. Person had a vaccine and they had cancer and they died because of their cancer. They didn't die because of the vaccine. And the stuff that gets on VAERS, there was one I saw the other day I put on Twitter. One of the adverse effect claims was a guy that got vaccinated, and he said that metal would stick to his arm, but a magnet wouldn't stick to his arm. So he was partially magnetized. I'm not Buddhist, but that's in the VAERS report as an adverse effect to the vaccine, even though we know, it's pretty loopy. So you can get numbers that are out there that people can't put into perspective. Again, we're not saying the average population is stupid. It's just you don't understand the systems if you're not in the area. So a lot of these vaccine complication rate issues are misinformation. And then, governments are, I'm not sure why the government would suppress an effective cheap treatment. It would make no sense, but governments are trying to suppress the use of hydroxychloroquine, which has been proven very, very many times not to be effective. Ivermectin, zinc, vitamin D, colchicine, you name it, anything but a vaccine. Now, to the reproductive issue, a lot of this comes back to some work. Unfortunately, a lot of the misinformation that's happening internationally is coming out of OBC, coming out of one or two faculty members here. And this is something that was put up. So this is information from a Japanese licensing study. So It's publicly available information, although it's being claimed it was secret information that these people found, but it was part of the regulatory submission. And this isn't looking at the vaccine, it's looking at the lipid nanoparticles, carrier parts of the vaccine. So they're injecting mice and looking where these things got distributed. And you see this graph where it only looks like, holy crap, there's a lot of it accumulating in the ovaries. And this has been led to people saying, okay, the spike protein accumulates in the ovaries. Well, it's not spike protein. This is the nanopart, the lipid. But look at the ovaries, it's really bad. And you look at this graph, it's believable, right? Well, you look at the real graph, there's where the ovaries are, down there. They're very, very low. You're in a parts per trillion thing. So, you know, we've got more, we're still all around the range of 0. You see there's conveniently no number on the axis here. But yeah, there's more in ovaries than bone marrow, but there's basically nothing anywhere. And it's the lipid nanoparticle. It's not the spike protein. And the vaccine spike protein isn't toxic. And this is done in mice with a 1333 times dose that we would get. But it's easy to see. Someone puts this graph up online and says, look at it accumulating in the ovaries. And the spike protein is toxic. And people are going to have fertility issues. You know, some of them said this is a WHO conspiracy for population control. These people are still getting a lot of attention. So that's the fertility side, is there is no evidence of fertility. A number of people in the vaccine trials for these vaccines last year got pregnant. They're large studies. So a lot of people got pregnant during the studies and had normal pregnancies. There was not any signal of problems with fertility, problems with abortions, problem with stillbirths, anything in people within the studies that were done. So we have no data supporting any fertility issues. This is another one that's going on there. And again, unfortunately, coming out of our area here, spike protein was found in circulation. So the general line has been you inject this mRNA vaccine in your arm and it stays in the tissue there. So, and one of the anti-vaxxers saying, well, it really doesn't, they're lying, it sneaks out. You know, a little bit gets into circulation, you know, because we have circulation. That's why something's going to get out there. But this is one of the things they've been saying, okay, spike protein was found in circulation 29 days after vaccination. And it's true, but it's 29 days after the first dose. It was only 1 day after the second dose. So it wasn't there 29 days after that dose was given. There was a little bit found in a really minuscule level 1 day after a booster dose. But this is being pushed widely as saying, okay, this isn't doing what they say it's doing. This is a paper that came out a couple weeks ago from a pretty bizarre group in Poland who said that, you know, for every 3 deaths that were prevented by vaccination, you kill 2 by vaccination. And that paper somehow made it into a journal, a borderline predatory journal that publishes a lot of crap. And it got retracted shortly thereafter because it was a bunch of the editorial board resigned. And then this same group put a paper out in JAMA Pediatrics last week or so saying that mass potentially harmful to kids with completely useless methodology. You know, and there's no expertise behind it. And it's the same group that had a paper retracted the week before. And the lead author here who's had this paper retracted and this other one, he just got fired a couple of days ago, I think. So there's been some really good takedowns of this stuff on Twitter. Twitter has a lot of crap on it, but Twitter also has some very good medical side if you're trying to look at some of this misinformation. And this is a good example of a nice thread that goes through the children and masking thing. And I won't go through it in detail, but there are issues like the paper was written by authors who have a clear anti-vaccine bias. It's a psychologist with no training in this type of research. The methods were useless for this type of thing if you talk to anyone who knows this methodology. And there's no there wasn't even any clinical evidence of a problem with the stuff that we found. So, but this gets picked up. And the problem is you can retract the paper, but that doesn't really address the whole issue because it gets out there. So there are a lot of issues with misinformation, and that's just scratching the surface a little bit. So I'm going to jump into the questions. I think we've got a couple more minutes, but keep tossing questions if you do. If I've missed any, don't be afraid to put them back in. This question about concern is difficulty socially distancing as exam rooms are 10 by 10. And that's the problem with the exam rooms, right? And that comes down to that Swiss cheese thing. So it's a small space. And if we wanted people in there, well, what do? Well, we try to minimize the number of people that are in there. So you're trying to have big groups in there. We try to minimize the amount of time we're in there. So if we have to do something to the animal, if the exam room, for me, I like to have them as like a holding room. So you come in, clients there, have a little chat, take the animal back, do what we need to do in the back room, bring it out there. So we've had less time in that closed space. But other parts of the Swiss cheese, right? So this is where masking gets more important because we can't do the spacing. And this is where ventilation is critical. So bringing in a HEPA filter, limiting the time when we're in there, maximizing the people that can still do curbside, so we don't use the room as much. There's more downtime and filtration time in between. All these things will help reduce that risk. Right? There's not one thing we have to do, it's multiple things. Maybe a similar question. The exam room that's 10 by 8, would you put a fan and a HEPA filter, or would a fan decrease the filter efficacy? Probably wouldn't decrease the efficacy, but it probably wouldn't help that much because your HEPA filter is probably going to circulate the air pretty well in that size of a room. So I wouldn't think a fan is going to be much bang for buck if you have a good HEPA filter in there. I think there was a question earlier about brand of HEPA filter, and I don't have one that I would recommend. I think there are a lot of good, reputable, I think if you find one from a reputable company, that's a little better than buying something from Amazon that's really cheap. But I don't have any specific information. I haven't seen studies that really looked at them. Would a ceiling fan in a small exam room potentially spread? And this gets into when you move air, it can do good or bad things. So a ceiling fan is going to help spread clouds. So if you got a cloud being built up, it's going to disperse that cloud. And that can be good or bad because it could spread it to other people, but it also drops the infectious dose. So HEPA filter is going to be more effective because we're moving air and we're filtering at the same time. Moving air in the absence of filtration is still better than not moving it because we're probably not making that high density aerosol cloud. But HEPA filter, I think, is a better approach. So the person who thinks they've had COVID with mild signs still be vaccinated. Any info on duration of immunity? And this is a big question. We don't know. There have been enough people that have been reinfected who were convincingly positive the first time and convincingly positive the second time that reinfection happens. We don't know how often it is. And we have no idea really of duration of immunity because there's no way we're going to figure that out. It also depends on the variant. So we know the Brazilian variant, what we used to be called P1, that one seemed to infect people that were infected before. There was a big outbreak in Manaus, Brazil, then P1 emerged and a lot of people got sick again. So there certainly is the potential for reinfection. I think the general guideline we're seeing now is a single dose of an mRNA vaccine for previously infected people is probably fine because you've been primed initially. So your single dose is like your booster dose. But we're not saying, you've been infected before, so you don't need a vaccine because, natural immunity probably isn't that solid and probably isn't that long lasting. So I think it shortens the vaccination course, but it's not going to negate the need for a vaccine course. Oh, great question about myocarditis. So myocarditis associated with, there are two issues here. Myocarditis associated with COVID and myocarditis associated with vaccination. So myocarditis does occur with COVID, absolutely, and it's a big concern. Myocarditis is a thing that occurs spontaneously in the, 4 per 6 per 100,000 in the general population associated with various infectious diseases, mainly in young men. There is a signal for myocarditis in vaccinated people with an mRNA vaccine, mainly in young, healthy men. It's typically almost always mild self-limiting disease. So yeah, it is an adverse effect. Like it's something that can happen. It's a mild adverse effect. It's an almost always self-limiting adverse effect. The disease that is preventing can also cause that adverse effect and more serious things. So like this is where myocarditis and caused by vaccine is very different than VIT, the thrombotic event, the immune-mediated thrombotic event that occurs from AZ vaccination. VIT is devastating, high mortality rate, hard to treat. Post-vaccine myocarditis is really mild. Mainly, there are always exceptions to the rule, but it's really low. So again, the cost benefit, and this is even the pediatric population, the American Academy for Pediatrics, they've said that the costs, so the benefits outweigh the risks even in kids, where the risk of serious disease is very low because there still is a serious disease burden. And for kids, we don't know what the long-term sequelae are, right? They may get mild disease, but does that, result in any chance of long COVID, which is a substantial issue. And one of the things we're worried about is 10 years from now, are we going to have a population of people that are 10 years along in terms of their brain function than it would normally be because of the damage that COVID does to the brain. So I think because we have enough unknowns in the long-term sequelae for this, we certainly want to vaccinate that population. I wouldn't vaccinate a young person with AZ because we know that occurs. We know it's higher than we thought originally, and it's a devastating disease, but an mRNA vaccine, the myocarditis risk is pretty low. Is it better to close the exam room door after the appointment and let the HEPA filter clean the air? Or is it better to keep the door open following the appointment? Great question. And I don't think we know. And that's really going to be clinic specific. It's going to depend on the airflow in the exam room. So how much, which way is the air moving? How much is moving? I don't think there's a single answer to it. If you have, it depends on the efficiency of the filter for your airspace. Like if you got a HEPA filter, like it'll say how much volume it'll clear per minute or per hour. So you'll have an idea how much circulation you're getting, how much filtering you're getting with that. So I don't think there is a standard answer. If you have a highly effective filter, you're probably better off closing the door because then you're really going to scrub that space well. But it's going to vary. So there's a comment you can see in the chat about the place at St. Catharines that had a HEPA filter, just FYI. When you think they'll allow kids under 12 to be vaccinated? It's a great question. And I don't think we know. It's certainly being looked at. Like my guess, and this is just my guess, is like if we look, where are we going to be 10 years from now? This is going to be a childhood vaccine and a vaccine that you get boosted when you're 65. I think we're probably getting shut down by EDA now.
Not shut down.
Yeah, I suspect this is one where we're going to get vaccinate young kids as long as there's a safe vaccine. And then you get boosted when you're older because we want to prevent deaths in that population. There's not really a reason that this shouldn't be a vaccine that can be given to young kids. It's just there's a lot more risk aversion with young kids. But the problem is we want to get the young kids back to school and we need high level vaccine coverage, and schools aren't doing a great job of anything else, like ventilation becomes an issue. I think there's going to be a lot slower rollout in the sub-12 population because of the hesitancy. Like a lot of parents are screaming to get their young kids vaccinated, but there will be enough hesitancy there. I think they'll want more of a prolonged safety study on that, be my guess. But I wouldn't be surprised if it becomes an option by the end of the year. That's pure guess. And I know I've heard lots of different opinions. We've had lots of different discussions about it. But that's kind of where we are now, I think. So I think, did I get through all the questions? And I rapid fired through some. So if there are any I missed,
pretty close.
I'll come back up. So I guess just to wrap up, my typical thing is my contact info. I guess it's on there now, but track me down. Don't worry, but people can find me easily enough. Track me down if you have any questions about this stuff or COVID stuff. If it's an urgent thing, put urgent in the title. For these, we were talking about before the webinar, when to do the next one, if to do the next one. So I think we'd be looking at your feedback. I guess that's what you're going to say next anyway. So I'll leave that to you. But thanks for everyone for joining in. Let us know what you think you want to talk about if you do later on.
Thank you, Dr. Weese. Thank you so much. And as you said, please send us some feedback about timing when you'd like to have our next town hall. We'd probably be looking at the end of the summer or certainly early fall. But of course, things can happen and change, and we might need one sooner. So do give us some feedback on that, and certainly subject area as well. It has been an absolute pleasure to serve you as CVMA's president this year and to be able to provide these wonderful town hall series. I'd like to really say thank you to Dr. Weese because he has been a pleasure to work with and an absolute savior during our moments of questions, and for our membership, it's been extraordinary. And also a huge thank you to Lori from our communications team who has been putting these together. And we just so much appreciate all of her hard work and our entire team of staff at CVMA. Thank you so much. So on that note, thank you again, and I will see you soon. Bye-bye.